My name is Jill Bates, and I am the PHASER National Pharmacy Program Manager, and I'm delighted to be here today to talk to you about DPYD and fluoropyrimidines. Again, I just want to go through a few ground rules before we get started for today. If you don't mind, please muting your phone or your computer depending on how you're receiving audio for today. I'm looking at our participant list, and I see quite a few people that are unmuted, and I can hear some feedback from that. So if you could please mute yourself. I am not able to mute you for you. So I would really appreciate that. Thank you so much. And then we also will have a chat function available. And so I highly encourage you, if you have questions throughout, we'll offer some time for questions and answer at the end to discuss the cases with our discussant today, Dr. Dave Wang. But if you have questions as we're going along, please feel free to type them into the chat window, and we will get to them as we move through the presentation for today. And so without further ado, let's go ahead and get started. And so today, as I mentioned briefly, we will be talking about germline DPYD variant effects on the toxicity of a class of drugs called fluoropyrimidines. And so, as I mentioned, that is a class of drugs, and so multiple drugs fall within that class, and we'll be discussing those today. So typically focusing our conversation on the medications fluorouracil and capecitabine. And so you also might have heard it referred to as 5-fluorouracil as well. And I am delighted to bring with us today our subject matter expert and discussant, Dr. David Wang. I'd also like to acknowledge and recognize Sarah Mills. Sarah is a PharmD candidate who is on rotation with me from the UNC Eshelman School of Pharmacy, and she had played a significant role in the development of this slide set and research to support this presentation today, so I'd like to acknowledge her efforts. And so here's an overview of what we'll be talking about today. And really what I want to encourage is a discussion type format, and so really do highly and strongly encourage you all to put questions up in the chat window. Dr. Wang and I will be sure to try to address all of the questions and give you high quality information about this drug gene pair. We'll begin with an overview of why this medication is impacted by the DPYD gene, and then we'll go through 2 cases and wrap up. And so it's my pleasure to introduce Dr. David Wang. As I mentioned, Dr. Wang is at the VA North Texas Healthcare System. He is our subject matter expert in DPYD. He is also affiliated as an associate professor in the Department of Internal Medicine at the University of Texas Southwestern Medical Center. So welcome to you, Dr. Wang. We're very grateful for your expertise today and your willingness to discuss with our group about this subject. And then, as I mentioned, my name is Jill. I'm the PHASER Pharmacy Program Manager at the Durham VA Healthcare System, and I'm also an Associate Professor of Clinical Education with the UNC Eshelman School of Pharmacy. So to begin, I mentioned we're going to be really focusing in our discussion on 2 medications, and those are capecitabine and 5-fluorouracil. Capecitabine, for those of you that aren't familiar, is generally taken as an oral medication, and 5-fluorouracil is an infusion. And you can see the algorithm and pathway, the metabolic pathway involved with 5-fluorouracil, and I'll mention that capecitabine is converted in vivo to 5-fluorouracil. So when you're looking at these pathways, you can kind of think of them together, even though they're 2 separate medications. But the mechanism of enzyme for these medications is you have a protein, deoxyribonucleotide, which binds to thymidate synthase enzyme, which inhibits the formation of thymidylate from uracil and blocks DNA and RNA synthesis, causing cell death. It is inactivated by the DPD enzyme. DPD deficiency will cause drug concentrations that increase, and that will lead to increased toxicity. And just to sort of clarify some nomenclature, DPD is the protein that is encoded by the enzyme, but it is encoded by the gene DPYD. And why do we even care about, DPYD deficiency and fluorouracil toxicity? Well, it can be extreme, and what you see are clinical side effects that result from fluoropyrimidine toxicity. You can see neutropenia, mucositis, stomatitis, diarrhea, nausea, vomiting, thrombocytopenia, leukopenia, fatigue, pain. It is associated when you have loss of function of the DPYD gene. It is associated with increased risks of early onset severe and life-threatening toxicities. So it's like these side effects, but on steroids. And so, in a perfect world, you would have the DPYD genotyping done, and you would know whether or not a patient has a normal functioning gene or not. And so when you're looking at genotyping of DPYD, you can stratify it into 3 categories of function with regard to the enzyme DPD. Normal metabolizer function, which means that the enzyme functions similarly to a majority of the population and what was studied in clinical trials and how you would expect dosing to move forward in a patient's body, versus intermediate metabolizer, which is reduced function, versus poor metabolizer, which is severely reduced function. And you can see here that we have from our expert consortium, the CPIC group, published guidelines that recommend therapeutic clinical interventions. And so we have outlined them there. So for normal metabolizers, as expected, you would just administer the drugs at standard dose. But if you had reduced function enzymes in any capacity, you would either reduce the dose or you would choose an alternative agent for the patient. And so what are the benefits of knowing this information prior to giving a medication like 5-fluorouracil or capecitabine? Well, you know what to do, and you know how to avoid certain side effects that can be severe or life-threatening, which, as you can imagine, would increase hospitalization and costs. So normal dose you could give to a patient. You could select a different drug, but if you gave the normal dose, you know that you would have significant toxicity, or you could reduce the dose to avoid toxicity if you knew the variant ahead of time. And so one thing to mention is that this gene and the interpretation of the gene is associated with something called an activity score, which is giving the end user an idea of what functionality that enzyme has. And so you can kind of see the ratings here. Poor metabolizers have lower activity scores, and then it changes from there. And then you can see that when you have alterations and select what they call single nucleotide polymorphisms, that you can predict whether or not there's a toxicity risk with great sensitivity, not with great sensitivity, but with great specificity. Excuse me. And so again, with preemptive DPYD testing, knowing that genotype ahead of time, we have opportunity to prevent early onset 5-FU toxicities and overall reduction in hospitalization and associated costs, which has been evaluated in pharmacoeconomic studies. And so I'd like to go through our first case for today. This is an 80-year-old male who had a basic preemptive pharmacogenomics panel drawn. This patient had a history of urothelial bladder cancer and was currently receiving 5-FU, mitomycin, and radiation. The patient also had multiple comorbidities as well, and unfortunately presented for severe mucositis and diarrhea that was thought to be related to 5-fluorouracil toxicity. Here are this patient's medications. You can see the patient was on several medications in addition to the chemotherapy. And his pharmacogenomics panel came back as follows. And so one of the things that we noticed when we got these results was that, the patient was suspected to have 5-fluorouracil toxicity, but the DPYD came back as a normal metabolizer. And so when we looked at this in detail, we found that the Sanford panel assessed 3 variants, but did not include HAPB3. And HAPB3 is located deep in intron 10 and introduces a cryptic splice site and partial production of a non-functional transcript, which does result in moderately reduced DPD activity. And so when we discovered this, HAPB3 is a relatively newly identified SNP. And so we worked with our partners at Sanford to look into the problem. We worked to identify external vendors that would be able to evaluate HAP-B3 for this patient. And unfortunately, we were not able to identify an external vendor that tested for HAP-B3. I will say that, and just a little bit more about HAP-B3 and its importance and why we're emphasizing this. In Europeans, it's the most common decreased function DPYD variant. Carrier frequency is 4.7%. So we did recommend that additional testing take place to rule out HAP-B3 variant. And as I mentioned, we were not unsuccessful in finding an external vendor that was able to test for HAP-B3. We did consider testing DPD enzymatic activity directly, but again, we're not able to find vendors that could help us with that. So in this case, we did end up giving empiric dose reduction of 50% for possible intermediate metabolizer phenotype, as well as potential for chronic kidney disease to be influencing a magnified toxicity in this case. And I will say that one of the things that came out of this case was that we were able to work with our reference laboratory, Sanford Health, and we are working to add HAP-B3 variant, which is awesome because that, as you saw illustrated from this case, is not available from external vendors. So that'll be a really great, significant advantage of our program and our panel once we get that in place. And so, I just want to stop here. And I'm looking at the chat. I don't see any questions yet. I myself have some questions for our discussant, if that's okay with you, Dr. Wang. How are you doing today?
I'm good. Thanks. Greetings to everybody from Dallas.
Greetings. Great to have you. Thanks so much for joining us today. And, one thing I just want to really ask if you could elaborate on is what happens. I mentioned that capecitabine is a prodrug, but is metabolized in vivo to 5-fluorouracil. And so, can you maybe clarify what happens to the amount of drug or the concentration of the active ingredient in the blood when the patient is exposed? What happens to the concentration of drug when the patient is exposed to a normal amount of drug, a normal standard dose, and the DPYD gene is mutated?
All right, so that's actually a great question. So fluorouracil is degraded or metabolized by this hepatic enzyme DPYD, or I guess DPD, the gene is DPYD, but that's about an 80% degradation. And the rest of the drug is metabolized to these different cytotoxic metabolites. So when you have a loss of activity of the DPD protein, for example, if you have DPYD mutation that decreases its function, then you just have increased levels of fluorouracil in the bloodstream, as well as the increased levels of all those cytotoxic metabolites. So as you can imagine, the drug and its metabolites sit around and cause quite a series of severe toxicities.
Oh, okay, great. Thank you so much for clarifying that. And is there any way to use the activity score to give you an example as to how you can expect that to manifest itself clinically for a patient?
Right. So if you're fortunate enough to proactively get a pharmacogenomics panel and you find one of the variants that are known to affect the metabolism and the function of the protein, you can basically predict what kind of dose reduction you need. And as you mentioned, CPIC actually has guidelines based on those activity scores. So we'll go over this a little bit some more on our next patient. But for example, the variant 2 really is a null allele. So you have zero function of the DPD protein. And so those patients should not receive fluoropyrimidines, and there your activity score is 0. So that kind of gives you an idea of how we kind of apply that if you're obtaining these results prospectively.
Great, thank you. And we went through some of the side effects, but given all of that and given that the concentration would lead to toxicities with the chemotherapy, one of the things that I always think about when I read that toxicity list is, oh, hey, these are the normal side effects from the chemotherapies. So what is different? What differentiates these toxicities resulting from DPYD deficiency versus in comparison to just routine toxicity from a fluoropyrimidine agent, for example?
All right, so yeah, that's another great question. So as you mentioned, those 8 side effects you kind of went through are all common adverse effects of cytotoxic chemotherapy. I think most oncologists, because the guideline panels haven't recommended that we prospectively obtain DPYD genotyping, actually respond to what we consider profound decreases in terms of neutropenia or prolonged neutropenia, or if the patients have side effects that are way over the scale of what we would expect. So these things happen, and I think we'll exemplify in this next case, that really we suspect it when patients really have a poor outcome.
Great, thanks. And I'll advance the slides for you, so just go ahead and let me know next slide when you're ready.
Okay. Yeah, so this is another case. Go ahead and go to the next slide. So this is an 81-year-old gentleman who had a history of a resected T2N0 cholangiocarcinoma, diagnosed in 2018 after presenting with jaundice. He did not have any adjuvant therapy at that time, given that it was no nodal involvement. So 13 months later, on surveillance imaging, he was found to have 4 intrahepatic lesions consistent with recurrent disease, and he was subsequently enrolled in a clinical trial and received gemcitabine and cisplatin. This was a SWOG trial, which he tolerated without any difficulty. After 3 cycles, he was found again to have progressive disease, this time in the peritoneum, based on imaging, and there was a discussion to move on to another regimen. So pertinent facts from his history is that he had a history of colon cancer in his siblings, but there was no discussion at all of whether they had tolerated that chemotherapy. You can see there his labs. He had a normal white count. He was slightly anemic and had a slight mild thrombocytopenia. All his chemistries were normal, except for his history of diabetes. He had a glucose of 300. So the treating physician at that time decided to proceed with second-line FOLFIRI, which is a common GI malignancies regimen. You can see the doses there. For the non-oncologist, the main thing to note is that he received 5-FU bolus as well as continuous infusion, and those were at the full doses based on his body surface area. Okay, moving on to the next slide. So 10 days after initiation of FOLFIRI, he presented to the emergency room with complaints of intractable nausea and vomiting. He complained of inability to keep anything down. He had very sore mouth, and this had led to a 7-pound weight loss over the 10-day period. He also complained of epistaxis, and then he had basically dark stools of loose consistency consistent with diarrhea. So on exam, he was found to have severe mucositis in his oral cavity. He also had a tender abdomen. He underwent imaging and was found to have a right lower lobe pneumonia, and diffuse thickening most prominent in his sigmoid and rectum.
Hello.
Also had.
Hey, it's Melanie. How are you?
I'm doing well. How are you?
Good. Can I ask a favor?
Hi, if you could please mute your phone. We can hear your telephone conversation. Mute your line, please. We can hear your telephone conversation.
Can you be my backup?
Yeah, that's fine.
Okay. I mean, I can take all the calls. I just won't be able to come in.
Yeah, that's fine.
Okay, cool. Thank you.
Mute your line, please. Thank you.
So the significant laboratory findings was that his white count was 0.19. His neutrophil count was actually an absolute count of 10. Again, his anemia was present, a little more severe, but here his platelets had dropped from the 130 range down to 26. Chemistries, again, showed a glucose of 300 and a bicarb of 19. And he had a rapid C. diff test sent that came back positive, but later was found to be toxin negative. However, he was started on treatment for C. diff colitis in the emergency room. All right, next slide, please. Basically, his hospital, during his hospital course, he didn't really improve. And so this was done at the university, but DPYD, full gene sequencing, and the Mayo assay was sent on hospital day 3. He was actually found to have this variant 2846A to T, and he was actually homozygous. And we know that this allele leads to reduced function. If you have a homozygous 2846A to T, variant, typically you have only about 40% function of DPD. And CPIC here recommends a greater than 50% dose reduction for fluoropyrimidines. Next slide, please. So unfortunately, this patient got sicker. He was admitted to the MICU on hospital day 4. At this point, he was growing gram-negative rods out of his blood, and his white count was actually even worse. White count was 0.09. Platelets had now dropped to 7. Around this time is when we got the results back for the DPYD genotyping, and he was given the antidote of uridine triacetate, 10 grams every 6 hours. Again, this was approximately 14 days after his initial dose of the fluoropyrimidine. He became tachypnic, somnolent, and the family agreed to intubation, hoping that this was just a transient thing. However, the patient had made known to his family that he did not want to be resuscitated, and shortly after intubation, he had a bradycardic arrest. Further care was withdrawn as the family had remembered what he expressed, and he unfortunately expired on hospital day 7. Okay, next slide, please. So this is how complicated metabolism of the fluoropyrimidines are. Jill had a very basic slide, which I think it has the take-home point. You can see DPD is there, indicated with the black arrow, and it simply shows the different metabolites that develop with the drug. So we already talked about how fluorodeoxyuridine monophosphate actually inhibits thymidylate synthase. However, on the right-hand side, you can see FUTP, which is fluorouridine triphosphate, and this is where the antidote actually works. You're providing uridine triacetate, which gets deacetylated to basically provide uridine for RNA synthesis, and actually does help with some of the common toxicities. However, typically the patients need to be treated within 96 hours of the dose of the fluoropyrimidine. So unfortunately for our patient, he got it about 10 days late, and I think that was just basically Hail Mary. All right, next slide, please. So again, here are the just a table of some of the known DPYD variants. We've talked about variant 2A, the 1905 plus 1G to A, which is a null allele, so you have no activity. Jill's case, there was a suspicion for this HAPB3, and so HAPB3 homozygotes have approximately a 50% activity value. Same thing with our patient, the 2846A homozygotes have about 50% of the value of our activity. And the other one I want to highlight is down at the bottom, the 1679 T to G, which is variant 13, basically is considered a no function. However, you still have some activity, so about 25% of DPD is there. But again, if you have that variant, many patients should probably be considered for an alternative agent. All right, next slide, please. Here again are some of the other alleles. However, these are all of the normal activity alleles. And CPIC, I think when I last looked on the website, had actually classified up to 83 different variants. So there are a lot of variants to be aware of. Next slide, please. So again, we kind of talked about the activity score. Normal metabolizers in the top. Since you have 2 alleles, the activity is 2. The intermediate metabolizers, as we mentioned, as in our patient, the 28046A to T. If you have a heterozygote of that, your activity score should be about 1.5. If you have this severe variant 2, or the other one, 1679 T to G, again, your activity score is probably closer to 1 than it is to 1.5. Our patient was homozygote for 28046A to T, so he was probably closer to 1 as well. And then you can see the poor metabolizers are if you have the null variant or this other 1679 T to G. You really should consider alternative agents. Next slide, please. Okay, so the conclusion for our case, which was quite catastrophic in terms of its outcome compared to the case that Jill had, is the severe 5-FU toxicity can occur in up to 30% of patients, while in terms of the frequency of just one of the high-risk alleles is present in less than 10% of patients. So this may kind of indicate why a lot of guideline committees don't recommend testing DPYD genotype prospectively. As an example, the NCCTG N0147 trial enrolled 2,886 patients who were to receive a fluoropyrimidine. And in this specific oncologic population, the frequency of having, I guess, an alternate metabolizer was actually much lower. So it was 2.1% of the patients had one of the three high-risk alleles. And then in terms of looking prospectively how to change dosing, there was another recent trial in Lancet Oncology that had 1,100 Dutch patients. And these patients were tested prospectively, looking for the four most common decreased DPYD variants, including HAP-B3. 8% were heterozygote carriers, while 92% of the patients were wild type. And so following the activity score dose reduction recommendations, they actually found that the relative risk of developing severe toxicity from 5-FU was actually close to 1, versus in patients who didn't have dose reduction was much higher, at least twofold. So as mentioned earlier, routine DPYD testing is not currently recommended by either ASCO or ESMO or the NCCN. So I think some of the new data is starting to change some minds. I think the FDA equivalent in the European Union has or is soon coming out with a recommendation to consider prospective testing of DPYD going forward.
Okay, great. Thank you. And we've got some questions coming into the chat window. So the first question is, do you have to worry, Dr. Wang, about reducing efficacy by reducing the dose in DPYD intermediate metabolizers or poor metabolizers?
So that's an excellent question. Some of these trials show that people still had the expected outcome in terms of benefit from the chemotherapies. If you're really concerned about that, I think Jill mentioned this briefly, that there are tests. You can actually get 5-FU dose levels, or you can also test conversion of the drug to uracil with from uracil to thymidine from a uracil load test. So there are ways to test if you're worried about efficacy to make sure you get the appropriate dose for the patient.
Great, thanks. And then for patient case 1, did he have a good response to dose reduction? So that's from Bethany. So Bethany, we were able to give him the antidote during his hospitalization that case number 2 got, and he did recover and was discharged from the hospital. And then we were able to avoid future hospitalizations in him. So that was good. So hopefully that answered all the questions. And Dr. Wang, anything else you'd like to add?
No, I mean, I think it's interesting. Again, obviously my case exemplified the catastrophic outcomes that can happen. I think oncologists need to be aware of this. And I'm glad that, agencies such as the EU equivalent of the FDA are becoming more proactive in terms of recommending DPYD genotyping. So it'll be curious to see how it happens going forward, how well it's accepted here on this side of the Atlantic.
And just one last question for our providers in the audience today. What would be a good workflow to preemptively test for the DPYD gene deficiency? And, if the provider wanted to test their patient, how would they go about doing that?
Yeah, so I think, the good thing is with most of our patients who receive fluoropyrimidines, there is time to get this test done. My understanding is that PHASER actually has a pharmacogenomic panel that includes this activity. So for veteran patients, it seems like that would be an easy way to get the results. And then I'm sure all of us who have academic affiliates that could also send out the test for us. So I think it's easily doable. I think the cost is relatively cheap as well. I think in Europe, they're quoting less than 100 euros compared to the cost of, that come with hospitalizations due to toxicity. So definitely something we should be considering.
Okay, great. Well, thank you so much. And any other questions from the audience here? Looking at any other questions, last chance. You can go ahead and unmute yourself if you'd like to verbally ask questions. I don't see any more in the chat. But otherwise, I'd like to thank Dr. Wang for providing and sharing his expertise. Thank you so much, Dr. Wang, for your time. And I'd like to thank all of our participants today for joining us. We're very grateful for you, and we hope to see you again in September on the 14th at 12 p.m. Eastern Standard Time. So have a great day, everyone. Bye. Thanks,
Bye.
Dr. Wang.